Hi, good morning or good afternoon. I'm Dr. Chrisandra Shufelt. I'm Associate Director of the Barbara Streisand Women's Heart Center, and that is in the Schmidt Heart Institute in Los Angeles. I also direct the Women's Hormone and Menopause program and co-direct our Cardiac Rehab Center here in the Schmidt Heart Institute. I'm going to be talking today about early menses or early menarche, menopause, hormone therapy, and cardiovascular disease. So I've got a lot of ground to cover in a good 20 minutes, but I hope the goal is going to be the concept of hormone therapy and cardiovascular disease very simplified in terms of what your take homes are for your patients. So I thank the committee and Dr. Bond for inviting me to give this lecture. I have no disclosures. My funding is NIH funded, and I'll be discussing some of our research. So we all know that there's an alarming fact is that the cardiovascular disease is the leading cause of death in the United States in women, and nearly every 80 seconds, a woman dies of heart disease. And we know that cardiovascular disease kills more women each year than all cancers combined. But over the last 3 decades, we've seen a dramatic decline in cardiovascular disease mortality in both men and women, especially women over the age of 65. However, what's very remarkable is that when women are under the age of 55, there's been this very much a plateau. And if you look specifically at women aged 35 to 44, there has also been a slight increase. So it's now turning to look more about what are the cardiovascular risk factors in younger women that can then help predict who will develop cardiovascular disease between the ages of 35 and 44 years. We are also aware that the ACC-AHA cardiovascular disease risk calculator is not capturing younger women, and a lot of that is based on the fact that the risk calculator is very age-driven. It has, however, taken into account a lot of traditional cardiovascular risk factors, and it has been of value to women and men who are of older age to capture risk. However, the women who are 35 to 44, we know that some of them can't even be entered in the calculator. And are there risk factors that are more specific that even precede that age that can then help capture risk in the women aged 35 to 44? And why are we still not capturing this risk, and what are we missing? There's been a lot of research surrounding pregnancy and adverse pregnancy outcomes, and that's actually now a novel risk factor for women. But are there other sex-specific and female-specific risk factors that we are also not capturing? For example, age at menarche. Age at menarche is really defined as the first occurrence of menstruation, and that's the marking of puberty. So this is the onset of ovarian function, and that is when we have an increased endogenous estradiol secretion by the ovaries, and that's when our first exposure happens. The average age of menarche in the United States is 12 years. And interestingly, however, the androgen and the adrenal secretion is not affected by the time of menarche. So that's more not related to chronological age, whereas endogenous estrogen exposure is. Age of menarche has been studied in large cohort studies as a potential risk factor for future risk of cardiovascular disease. And this was from the UK Biobank study of over 500,000 participants. And this study found that early menarche under the age of 12 years, so that's the average age in the United States, but very much in also developed countries, was associated with a twofold higher rate of adult obesity as well as metabolic syndrome. There's also shown an increased risk of breast cancer, but that has been suggested that it was partially due to lifetime exposure to endogenous estrogen. What about age of menarche and coronary heart disease? And this is also from the UK study. So this is 1.2 million women without coronary heart disease that were followed for approximately 11 and a half years. And you can see in this U-shaped curve, there's very much a U-shaped distribution of the relative risk for developing coronary heart disease, in that the women under the age of 12, and specifically early puberty under the age of 10, had an elevated relative risk of coronary heart disease, while on the other spectrum as well, young girls who are entering menarche at a delayed rate, so over the age of 16 and specifically over the age of 17, also had an elevated relative risk. And this is after adjusting for all traditional risk factors as well as hormone therapy exposure. We looked at this as well in the Women's Ischemia Syndrome evaluation. So this is a cohort of women who've now been followed for almost 2 decades. And this is an evaluation of women who are coming in with chest pain and getting angiograms for evaluation for their chest pain, and it's funded by the NIH. This Women's Ischemia Syndrome evaluation, we were able to identify 648 women. Their average age at this time was 58. They'd undergone coronary angiogram for suspected ischemia, and they'd been followed in this cohort for a median of 6 years. We define MACE as non-fatal MI, stroke, heart failure hospitalizations, and death. And we adjusted for all traditional coronary vascular risk factors, as well as lifetime estrogen exposure. We took that a little bit to another level because we defined total estrogen time as an estimate of endogenous exposure over a woman's lifetime, meaning when they started their menarche to when they went into menopause. And then we had a supra total estrogen time. So this included identified women that had exposure of supraphysiological levels. So not only did we take into account their menarche and menopause, it also took into account endogenous as well as exogenous. So the times that they were pregnant, as well as when they were using oral contraceptive use. As we had all of this data, we were able to control to see if it was perhaps related to or not related to estrogen exposure. Our results found very similar to what the UK Biobank study did find, that age of menarche and major adverse cardiovascular events had an increased risk. So menstruation earlier as well as later than the average in the United States at the age of 12 years was associated with a higher cardiovascular risk. And more specifically, the younger women, 10 years and younger, we found almost a 4-fold increased risk of developing cardiovascular disease after adjusting for estrogen exposure, as well as traditional cardiovascular disease. This held true whether a woman was exposed for just the total estrogen time, but also true for when a woman was exposed to those supraestrogen time, suggesting that it's not the estrogen exposure that was relating to the lifetime estrogen exposure, was related to the cardiovascular risk. So while an increased estrogen exposure at early menarche has been associated with breast cancer, we did not find this estrogen exposure was linked to cardiovascular events, as well as the supraestrogen exposure. So what are factors that are linked to earlier menarche? That's actually psychosocial stress. So psychosocial stress plays a stronger role in predicting which women will go into early menarche, as well as overnutrition. And what are factors that are linked to late menarche? And late menarche has also been linked to things like PCOS, excessive exercise, so hypothalamic amenorrhea, as well as undernutrition. Late menarche may be linked to relative hypercortisolemia, whereas early menarche has been linked to metabolic syndrome, as what's been shown in the UK Biobank study. And what both of those really hold a common link together is a chronic state of inflammation. So it perhaps is an immunoinflammatory response related to early menarche as well as late menarche that is we're finding a signal outside of exposure to estrogen. So we're going to turn now to talk about cardiovascular implications of low estrogen during the reproductive years. So these are the years between the ages of 20 up through perimenopause, which is approximately 45. So that would be the reproductive definition. So what would the implications of having low estrogen levels during this age, and what are some of the causes? So what are some of the causes of premature estrogen loss? And then what is the sequelae on cardiovascular risk? Causes of premature estrogen loss in a reproductive woman, and most commonly, is premature menopause. And that can be defined several ways. So there's surgical menopause, so surgical removal of the ovaries. And there's chemopause, so a lot of women undergo chemotherapy and end up having their ovarian function decline or halt. And there's several that need to be discussed prior to women starting chemotherapy, if there's a need for fertility preservation. And then there's premature ovarian insufficiency. So these are younger women in their 20s and 30s that have an elevated FSH and a low estrogen. They usually find this out during reproductive years. So this is data from the Framingham study, and this is a cohort of women that were divided into the age that they entered the study, and then if they were premenopausal or postmenopausal. So you can see at all ages, whatever the age was, whether it's 40, under 40, which is considered premature menopause, 40 to 44, or 45 to 50, which is the average age of menopause, and 50 years and beyond. But any age that a woman entered postmenopause compared to premenopausal years, there was almost a 2 to 4 increased risk of incidence of cardiovascular disease per 1,000 women. So suggesting again that no matter what age you enter menopause, an abrupt loss of estrogen during specifically also the reproductive years, that under the age of 40, resulted in an elevated risk, and this was regardless of estrogen status use. Surgical menopause and surgical menopause specifically under the age of 35. So a lot of women are electing to have surgical menopause due to genetic reasons, bilateral removal of the ovaries, an oophorectomy, versus a hysterectomy without an oophorectomy in the blue, resulted specifically in the younger women. You can see a very high relative risk of non-fatal myocardial infarction. So now we're looking actually at heart events. This held true, almost a 2 to 1 ratio in women 35 to 39. So if you have a woman who's electing to have a bilateral oophorectomy versus a hysterectomy without a conservation of the ovaries, so remaining of the ovaries, it will be important to counsel women and aggressively manage their cardiovascular risk factors going forward, specifically if they're if they're having surgery under the age of 40. And this holds true now for the AHA-ACC guidelines. We're all familiar with our cardiovascular risk calculator, but these are now risk enhancers. And I draw your attention to condition specific in women. And while I'm not covering adverse pregnancy outcomes, they are considered a risk enhancer. But you can see specifically premature menopause is now considered a risk enhancer. So that's entering menopause, whether it's surgical or whether it is natural under the age of 40 is considered a risk enhancer. So if you have a woman who falls into that category of a moderate risk and you're using the risk enhancer to determine if a statin is necessary or not, you need to take into consideration what age she enters menopause. And this is just reiterating that 5 to 7.5% borderline risk. So if a risk enhancer is present, then discuss regarding moderate intensity statin therapy. And if the risk decision is uncertain or if the patient is still reluctant, consider the coronary calcium scan. The current recommendations, and this is very much a wide array of societies that support this statement, including the North American Menopause Society, Endocrine Society, and ACOG, but also many international societies. The recommendation for premature menopause, if not contraindicated, an estrogen-based hormone therapy should be given to women who enter premature, that's under the age of 40, or early menopause, that's under the age of 45, until the average age of natural menopause. And that average age of natural menopause is 51. In my clinic, when I see patients, it really is about explaining if the risks are not present in terms of estrogen-sensitive cancers or cardiovascular risk. It's very much important to start these women on hormone therapy, because comparing them to an age-matched woman, that is having their menstrual cycles, that woman is still having endogenous estrogen. So that's how I explain it to my patients. So it's either oral or transdermal that achieves the replacement levels of estrogen that's recommended. And of course, if a woman has a uterus, to add on a progestin or progesterone. An estrogen after oophorectomy does not increase the risk of breast cancer among patients with the BRCA mutation. That is not a formal position statement or guideline. That is very much supported by science, but it has not come out as a formal statement. But we do know that that is to be true. And these are women that we certainly know, breast cancer survivors and BRCA mutation survivors, or women that carry the BRCA mutation, are going on and preventing their breast cancer incidence, but then we don't want them to go on and develop cardiovascular disease. So this is an important discussion with your patients. So let's now turn to the current data of risk versus benefits of hormone therapy. And I will speak to the fact that the medical societies are turning away from calling it hormone replacement therapy because it's not necessarily something that we need to replace, but it is hormone therapy for women who are symptomatic. And in terms of other terminology, we also use the term MHT, which is menopausal hormone therapy. So here we've got someone considering hormone therapy, but she's got a lot of other things that need to be replaced first. It's of note that 80% of women have menopausal symptoms, and the average age of menopause, I mentioned previously, is 51. So the menopausal symptoms most commonly are hot flashes and night sweats, and you want to consider quantifying if they're having bothersome hot flashes, which are really considered moderate to severe. So these are women, as we can see, they're finding cool sources to cool them down. It's not necessarily that it's necessary to determine if their quality of life is disrupted. And you can see if someone's walking down the aisle of the grocery store and putting her head in the freezer, that's a quality of life that's pretty disrupted. And I've gotten to the age in my career that a lot of women on the right, the woman on the right isn't recognized, but that's a golden girl. So for everyone that's seen that show. So what we thought we knew, we thought estrogen therapy was a logical hypothesis because what happens at menopause is we decrease estrogen, and then what happens at menopause is an acceleration of cardiovascular disease. So the hypothesis and what was epidemiologically presented was that estrogen was cardioprotective. So at the time in the early 1990s and before that, hormone therapy was the most commonly prescribed medication, and it was really based on a hypothesis. And incredibly, in the 1960s, Dr. Wilson wrote that menopause was a disease. And instead of being condemned to witness their death of their womanhood, women would remain fully feminine, physically, emotionally, as long as they could live, and that menopause, which was a disease, was curable. He went on to say that the women that were on hormone therapy were much more pleasant to live with. So it's a pretty incredible essay that was published and would not really fly today. I would hope not. The Women's Health Initiative, however, was the first clinical trial that was designed to answer, does hormone therapy prevent heart disease as well as other chronic diseases? It was not a trial to answer the question, does hormone therapy prevent hot flashes? We already knew that. So by design, this was a primary prevention trial that randomized 26,000 women. Approximately 16,000 women were randomized to estrogen with progestin because they had an intact uterus versus placebo. And about 10,000 women were randomized to estrogen alone versus placebo because they had a hysterectomy. By default, these women were a double-blinded placebo-controlled trial, so they could not have extreme symptoms of menopause. And so the average age was 62. And I mentioned the average age of menopause being 51 in the United States. So by design, these women were already about 11 years since menopause. I'm not going to go into great detail, but you can see the results very much paralleled what the observational trials had found, similar to stroke, as well as pulmonary embolism and breast cancer increased risk. But what was discordant was the difference between the observational studies showing protection for cardiovascular and the Women's Health Initiative showing an elevated increased risk for cardiovascular disease. And what happened was overnight was an earthquake on the Richter scale. So every woman received the results that hormone therapy increased the risk of cardiovascular disease, of breast cancer, and all of the covers of major magazines that aren't even around today, did find that there was an increased elevated risk. And so women stopped their hormones overnight. They abruptly stopped because they considered that was their individual risk. They were at a 100% increased risk of developing certain blood clots, strokes, breast cancer. So most women stopped their hormones overnight. What's been learned in the last 15 years since the results of the Women's Health Initiative is standing back at the 10,000 foot level, you can see that not even looking at what all the small details are here, I'm going to walk you through. These are women 50 to 59 that were enrolled in the trial. That was approximately 12% of the study cohort, 60 to 69 years at the entry of the trial, and then 70 to 79 years. I'm going to show you that regardless of looking at all the small details, but this is coronary heart disease, breast cancer, stroke, the upper bands represent the estrogen with progestin, and the lower bars represent the estrogen alone trial. But you can overwhelmingly see that the women who were 50 to 59 had a much lower incidence of developing any of these diseases, when you look at the dark bars, which were the active treatment, comparing to the placebo. And in fact, in the estrogen alone trial, there was higher coronary heart disease in those that received placebo, as well as higher invasive breast cancers for those that received the placebo versus estrogen alone. And what we've learned since that time is called the timing hypothesis. And the timing hypothesis really speaks to the fact that if we're looking down a coronary vessel and the vascular health of the coronary vessel is healthy, the estrogen receptors are embedded within the endothelium of a coronary vessel, as well as other vessels throughout the body. And if it's a very healthy blood vessel, there you get vasodilation when estrogen binds to that receptor, and it decreases inflammatory activation. And could it potentially decrease lesion progression? Perhaps. It has not been studied in outcome trials yet. But if you look on the right-hand side, you can look down the barrel of this blood vessel, and you can see there's an atherosclerotic plaque. This might be a minimally obstructive plaque, but you can see that there's plaque present. And you get dysfunctional endothelium. The estrogen receptors are buried underneath this plaque, and the concern is that in a fibrous capsule, estrogen, specifically oral estrogen, one of the byproducts of breaking down that estrogen in the liver, increases some certain enzymes, including MMP, and that can actually break down the plaque and cause plaque instability and therefore rupture. So the timing hypothesis speaks to the fact that perhaps women that were in this study that were of average age 10 years after menopause had already established some plaque, and perhaps that's the reason for the discordance between observational studies, which enroll usually women closer to the age of natural menopause and perhaps had healthy blood vessels compared to women who have diseased vessels. And what's the individual risk now when you counsel women who are 50 to 55 years old that are considering hormone therapy for their bothersome menopausal symptoms and quality of life? Well, the individual risk to a woman really is really breast cancer after 5 years of continuous use. Estrogen with progestin, there's a 3 per 1,000 women risk of breast cancer compared to estrogen alone. There was no increased signal for breast cancer seen. You can see there is very minimal risk for coronary heart disease, stroke, as well as DVT. What's the updated terminology we're now using? These are the most updated guidelines and position statement from the North American Menopause Society. Lowest effective dose for the shortest duration of time is out. That's the old terminology. Our new terminology is more about individualization on the appropriate dose, appropriate duration, and appropriate route of administration for women who are having bothersome symptoms. So if you have a woman with moderate to severe symptoms, yes, and she's interested in hormone replacement therapy and free of risk factors that we would consider alternative treatments like DVT, PE, stroke, TIA, or breast cancer. The breakdown now is in terms of ASCVD risk. So if a woman is within 10 years of menopause, you can certainly see, and they're at low ASCVD risk, hormone therapy is appropriate and okay to use. If they're at moderate risk and they're within 10 years of their menopause, it's appropriate to use a transdermal hormone therapy in low dose. But if they are greater than 10 years since menopause and they are at high ASCVD risk, the recommendation is to avoid hormone therapy. And no longer are we saying there's an expiration or there's a shortest duration of time. It's more about the continued moderate to severe symptoms if you taper down and their bothersome symptoms return, or patient preference, as well as risks of breast cancer, that 3 per 1,000 women after 5 years of continuous use, cardiovascular disease, and osteoporosis. Is there a transdermal advantage? This is what's really been evaluated since the Women's Health Initiative, which was studying oral synthetic estrogens. There is believed to be a transdermal advantage because it avoids first pass metabolism in the liver, and then that results in less clotting factors, less triglycerides, CRP, and such. You can see that there's also less effect on blood pressure. But there's no large randomized trials to date to look at outcomes. There are some relative small studies of around 700 women in the KEEPS and ELITE trial that suggest, specifically the KEEPS trial that suggests that the intermediate markers such as IMT as well as CAC might not be impacted. What if a woman is having symptoms, but they're not free of heart disease, having a stroke, or other contraindications to hormone therapy? There are treatment options and women don't need to suffer. This is non-hormonal therapy. There are good SSRIs and SNRIs, as well as gabapentin. Why do the SSRIs work? Well, this actually has to do with the area of the brain and the hypothalamus that controls hyper and hypothermic perception, and that's based on serotonin. So that's one of the reasons that low-dose SSRIs and SNRIs work. And I find it very helpful for women if I'm going to prescribe that medication to them to explain why they're using it and not that they were using it for depression. The candy neurons are the new and upcoming and exciting area of non-hormonal treatment, and this is something to pay attention to, especially in our cardiac patients who might not be able to use hormone replacement therapy. These are the kisspeptin, neurokinin B, dynorphins, and they play a central role in hypothalamic function. So they tightly regulate GnRH during reproduction, and it was found that an infusion of neurokinin B in young premenopausal women resulted in hot flashes. So there was in phase 2B now, there's neurokinin 3 receptor antagonist, fezolinetant, that showed to reduce hot flashes by 84%. So this is something now exciting that we can actually look at an option to really reduce hot flashes in women who can't take hormone therapy, because the SSRI and SNRI class of medications are about 60 to 70% effective. So in summary, I would just welcome that we need to recognize more emerging and novel risk factors in women, such as age of menarche or early menopause. Best candidates for hormone therapy are women who are symptomatic and recently menopausal and at low baseline cardiovascular risk. And women with cardiovascular disease or really strong cardiovascular risk factors that increase their ASCVD should be carefully evaluated for the risks and benefits of starting hormone therapy, and additionally, understand that there are non-hormonal options to treat their symptoms. Thank you very much for your discussion today and inviting me to give this lecture.